So, Erik Kubiak from Las Vegas, Nevada. Today, we're going to demonstrate application of the extra-articular humerus plate through a Gerwin posterior approach to the humerus. We'll go through some anatomy, show you the salient structure at risk, which is the radial nerve, and then go through plate length options. My preference is to do these operations without the tourniquet, for the reason being that the tourniquet tends to shorten the surgical field and puts the radial nerve, which is the structure at risk, potentially tethered and stuck under the plate. So of the plates, this is the shortest. This is the longest operating. Holes increase by 2 holes as we escalate the plate sizes. You can see for this specimen, this person, the longest plate would be too long. These plates are differentiated from the conventional periarticular distal humerus plates in that they're much thicker. They're a 3-5 plate in stiffness, whereas the conventional periarticular plates are thinner and less stiff. These are really meant to treat those hybrid fractures, which are a combination of a shaft metadiaphyseal injury to the distal humerus. I tend to use these plates more than I use the periarticular plates. I tend to fix most of these with a longer, stouter lateral plate and then the appropriate medial plate. The design concept here is that the shaft plate and the periarticular plate have very similar distal screw pattern to address the periarticular fracture. This distal screw cluster can either use the 3-5 screws or 2-7 screws. I tend to treat most of these fractures with a stout lateral plate and appropriate periarticular medial plate as necessary. The only difference in the distal screw pattern between the periarticular plate and the extra-articular distal humerus plate is the addition of this cross tab, which would allow a screw across the trochlea. Important features of a direct posterior approach to the humerus would be positioning. So mostly patients, we're doing lateral over an arm holder. Other people do them prone over a similar arm holder with the elbow to be able to extend it or flexed. The incision is centered over the center of the triceps. For an extra-articular injury or an extra-articular humeral shaft fracture, I often don't need to develop the medial side of this approach. If you do not develop the medial side, I would say you have to be very careful of the ulnar nerve or trapping the ulnar nerve, which is just on the other side of the humerus. So retractors placed under the triceps can catch the ulnar nerve and inadvertently injure it when the patient triceps is immobilized out of the way. The easiest way to do this is in skin incision down on the fascia, overlying the triceps, open the triceps fascia, and then elevate the triceps off this overlying fascia. That'll allow you to find the cutaneous branch of the radial nerve, which then will take you to the radial nerve. When you're actually doing the live dissection, the vessels that travel with the radial nerve can be quite bloody. And so we use a bipolar cautery because you're cauterizing right around the nerve, and it's easier than using the pickups in the cautery, electrocautery. The other thing I would say is when you're doing this approach and you're mobilizing the radial nerve, make sure you can get underneath of it and make sure you can get underneath of it proximally and distally. Most of the time when I'm doing this procedure, I'm demonstrating it, we go up all the way to the deltoid and come to the confluence of the 2 heads of the triceps and the deltoid. That kind of marks the top of this incision for me. Once I'm here, then I can track back. If you're having trouble finding the radial nerve, go to a place that's safe distally, work proximally, go to a safe place proximally, work distally, and find the nerve between the 2 approaches. That's a really easy way to get at it without getting in too much trouble. When you need to do that, most of the time it's because this is a fracture that's gone on to non-union and you're picking the nerve out of the non-union ball. So in that circumstance, just come somewhere where you're safe proximally, somewhere you're safe distally, and work until you find the radial nerve in between the 2. One of the important points of humerus fractures is the humerus has some curve to it in the anterior posterior plane, or in the coronal plane, it has a radius of curvature. These plates also have a radius of curvature in that coronal plane. This particular patient has an extra kind of kink in the distal third of the humerus, where if this was broken, we'd probably just take the kink away and reduce it, take this. But in this circumstance, we had a put a little bit of a bend in the plate to facilitate her anatomy. Again, the plate's going to come up under the radial nerve, be fitted to the distal humerus and the shaft of the humerus. Be really careful of the radial nerve. Try not to wind it up in the drill bits, screws, etc. And then in the dictation, we always dictate where the nerve passed over the plate. So in this circumstance, we would say the nerve passed over the first proximal hole. Again, true 3/5 screws. So a 2.5 millimeter drill bit. Bicortical. This should always, in most human beings, this can be 26 to 28. So this is measuring 26. Titanium is really nice. Now, the one thing I would say is in this circumstance where the pulling the apex into position tended to lift the one end of the plate or the other off, I would fix to the metaphysis first because that's going to be my dominant thing that I'm worried about. Fix the metaphysis first and then draw the bone to the plate. Calibrated drill guide has 2 marks on the drill bit. The first mark is for the short side, so up to 50 millimeters. So as you can imagine, we're at 15 and there's 15 millimeters of drill bit exposed. If you come up to the second line, drilling across the trochlea, the double mark starts at 55, 60, 65, 70. Drilling towards the coronoid, if you're really in the coronoid, can be up to 30. Most of the time down here, it's going to be 16, something like that. So we're at 26 here. So 26.27. My preference is pin the plate, conventional compression screws, and then if locking screws or fixed angle screws are indicated, i.e. secondary to bone quality, then I would go to the fixed angle screws or locking screws after I'd already put the cortical screws in place. You can see how the plate pulls really nice down to the bone, appropriate to the bone. Once that plate's appropriate to the bone, the other cortical screw, and you've got this like really, really perfect plate contour, plate sitting against the humerus, appropriate. So this will be the intermediate step of this procedure. You have the plate pinned to the bone, fracture reduced, plate pinned to the bone, and then the cortical screws pulling the bone plate construct so that's appropriately fit. Now, when you look from the lateral, sort of at the lateral aspect of the humerus, you can see this really nice plate contour fitting the humerus appropriately, appropriate to the bow of the humerus, and a really nice distal fit to the distal humerus, which is going to be important because there's not a lot of soft tissue on the distal aspect of the lateral column of humerus if you feel it, and people will feel that plate pretty easily. So the number one reason to take these plates out is that distal lateral prominence. And again, that's why you got to be a little careful about the radial nerve because you're going to be pulling these things out. So we're going to demonstrate the 3/5 distal lock. It's a 2.5 millimeter drill, 2.5 millimeter calibrated cannula. Same concept with the single mark, marks the depth. When I place this screw, I don't try to go bicortical because I know it's going right for the coronoid and the radial head. So here we're 22, 3.5 millimeter locking screw. With the torque limiting attachment, which if you're going to place the locking screws with power, I would always recommend using the torque limiter. And then you can come back and address them by hand at the end to make yourself feel better. But I would always use a torque limiter with power. When we first pull the plate down, often we're measuring a screw from a plate that's not on the bone. For me, I wouldn't pull it down and don't change these screws, which are obviously long on the lateral. The distal screw is obviously long. I would place the distal locking screw first before changing this screw and shortening it. If you don't do that, then the plate can pull off the bone. You can lose the reduction. The goal in my life is to obtain the reduction and then maintain that reduction until the patient's healed. and nowhere along those lines sort of lose the reduction. So I don't want to lose the reduction once I've sort of gotten the fixation started. So this screw will be shortened after the definitive locking screws are placed. Final plate bone construct, demonstrating a typical pattern of fixation with multiple screws placed into the capitellum. These screws, for me, fixed angle. Variable angle screws are helpful because I like divergent or convergent screws to really maximize fixation in this distal metaphyseal bone. The distal fragment will also have a minimum of a cortical screw and a fixed angle screw to really lock in that lateral column. Again, we'll go through the typical spiral fracture of the distal humerus. The proximal shaft fragment needs a minimum of 3 points of fixation. That's going to be, in most intents and purposes, a cortical screw to help hold the plate bone construct where it needs, and then backed up by locking screws or fixed angle screws at a minimum, I would say, of 2, but I like 3 is kind of the number that I'm going to shoot for. And again, the radial nerve crossing over the top of the plate and making sure that all the additional K wires are put in, all that stuff's removed.